Hey, welcome back. This week we're going to talk about drug exam 14. These are medications that are given in cardiac arrest. There's just four medications this week that we're going to talk about, and these are the medications we will be using a lot in our ACLS class. First one we're going to talk about is epinephrine. Epinephrine or adrenaline is a sympathomimetic medication. It acts on the alpha and beta receptors as an agonist, and it causes positive conotrope, positive inotrope reactions to the heart. What does that mean again? Conotrope means increases the heart rate. Inotrope means that it increases the contractility of the heart, makes the heart squeeze harder. So we're trying to, when we're giving epi in a cardiac arrest, we're trying to get that heart to restart and to get going again on its own. The dose in cardiac arrest for epinephrine is 1 milligram every 3 to 5 minutes. Now that's got a little bit of a range there, but if you really kind of go for the middle, it's really every 4 minutes. And if you think about back to CPR, we check a pulse every 2 minutes. So really, ideally, in a cardiac arrest situation, we're going to be giving epinephrine 1 milligram every other pulse check. Be careful with giving epinephrine for a patient that is having a potential myocardial infarction, because it does increase the heart rate, does increase the contractility, therefore it increases the workload of the heart and increasing oxygen demand. So if they're infarcting and the muscle is already starving for oxygen, if we make the muscle work harder, it's going to need more oxygen. Therefore, it's going to cause more oxygen deprivation of the cardiac cells. Next medication we're going to talk about is lidocaine. When we think about lidocaine, sometimes we think of it as a medication that is for someone who's getting stitches, but we use it in cardiac arrest for any shockable rhythm, any VFib, pulseless V-tach, any rhythm that the patient is in that we would need to defibrillate, we will give lidocaine. Lidocaine is the dose for lidocaine is 1 to 1.5 milligrams per kilogram IVIO. So if you think about that, that range is pretty wide, and that allows us for a lot of our patients to fall into that 100 milligram vial that we carry typically on the ambulance. So we just can push that. If you have a patient that is as low as 50 kilos, we can give them a little bit less, but 75 kilos, you can give them 100, 125 kilos, you can give them 100 based on those, the math. So that's kind of where that comes from. The next medication we're going to talk about is sodium bicarb. Sodium bicarb is a medication that we give to reverse acidosis. Now, in cardiac arrest, we see sodium bicarb given a lot later in cardiac arrests to try to reverse that acidosis, because we're assuming acidosis, and I think that is a fair assumption. But the routine use of sodium bicarb in cardiac arrest is really not shown to have any benefit for our patients, with the exception of for patients that are having cardiac arrest from potential renal issues. If you have a patient that's on dialysis and they have missed dialysis yesterday and they're in cardiac arrest today, we can assume that they're hyperkalemic. And if they're hyperkalemic, we do want to give that sodium bicarb, because sodium bicarb causes renal bicarb excretion, renal acidosis, renal hydrogen ion expulsion. So it will help us increase our pH by getting rid of those hydrogen ions. But we see it given a lot of times in the cardiac arrest situation. The dose for cardiac arrest is 1 milliequivalent per kilogram. The vials that we carry, the 8.4% sodium bicarb, they have 50 milliequivalents in it. So the dose is 1 milliequivalent per kilo. So in the vast majority of cardiac arrest patients that are adults, if we are giving sodium bicarb, we are underdosing the amount of sodium bicarb we're giving. If you think about it, a lot of times when you see people give sodium bicarb, you see them giving 50 milliequivalents. Well, that's only going to be enough for your patient that weighs 100 pounds. If your patient weighs 250 pounds and you're only giving them 50 milliequivalents of sodium bicarb, you're way, way, way underdosing. So keep that in mind that that dose is 1 milligram per kilogram. Also, be careful giving sodium bicarb for patients that are hypovolemic because that uh, medication is very hypotonic. So it will cause fluid shift through osmosis and will just make our patients more hypovolemic. So we really want to be careful with that. Last medication we're going to talk about today is amiodarone. Amiodarone is kind of used as uh, the first line medication for VFib and pulseless VTach. The dose for it is 300 milligrams is the first dose, and the second dose is a half that, so 150 milligrams after 10 minutes. Uh, the nice thing about it is you only have to give it twice, and then that's done. It is a medication that a lot of places carry. Some people will say that they prefer lidocaine because lidocaine comes pre-packaged and ready to push, where with the amiodarone, you have to draw it up before you give it. So there's some benefit there. And really, there's a lot of personal preference in this because there's no studies that have shown that amiodarone has positive neurologic outcomes any greater or any less than lidocaine. So as a provider, you are given discretion to whether you want to use lidocaine or uh, amiodarone based on your local protocols. Some agencies don't carry amiodarone. Those are very few and far between anymore, but the vast majority of agencies now do. But we still tend to see some people going back to that lidocaine because it's what they know, it's what they've always given. But we can use it interchangeably with lidocaine, one or the other. We don't want to give both, but we want to give one or the other. And ultimately, that's your choice. You will have people that will say amiodarone works better. You will have people that say lidocaine works better. But there's no real studies out there that have shown that one of those works better versus the other. So that's really all the medications we're going to talk about this week. If you have any questions, please don't hesitate to ask your instructor. And we will see you next time right here, same place.